Hello everyone, my name is Vivek Goswami, student of Medical Academy named after S.I. Jarvisky of Varnadsky CFU. My conference topic is Operations on Pancreas under the supervision of Professor Igor Vladimirovich Zadny. First of all, we will start from Operations on Pancreas. Topography of pancreas. The pancreas is both an exocrine and an endocrine gland. The exocrine portion of the gland produces a secretion that contains enzyme capable of hydrolyzing proteins, fats and carbohydrates. The endocrine portion of the gland, the islets of Langerhans, produce the hormone insulin and glucagon, which play a key role in carbohydrate metabolism. Functions. It plays an essential role in converting the food we eat into fuel for the body's cells. The pancreas has two main functions, an exocrine function that helps in digestion and an endocrine function that regulates blood sugar. The head of the pancreas is disc shaped and lies within the concavity of the duodenum. A part of the head extends to the left behind the superior mesenteric vessels and is called the unicutinate process. Holotopy, scalotopy, and syntopy. Now we will talk about holotopy, projected on the umbilical and left hypochondric region. Scalotopy had two lumbar vertebra, body first lumbar vertebra till 12th thoracic vertebra. Syntopy, anterior transverse colon, lesser sac and stomach. Posterior common bile duct, portal vein, splenic vein, inferior vena cava, aorta, superior mesenteric artery, and less serous major muscle. Inferior transverse colon. Surgery of the pancreas. Different routes for exposure of the pancreas. The pancreas may be reached either through the anterior or posterior abdominal wall. Anterior route. This can be accomplished in six different ways. Uh, Through the gastrohepatic ligament. This route is advisable only in cases in which either there is a marked gastropoiesis or if the pancreas is situated higher than normally. The latter is a rare condition. B. Through the anterior and posterior walls of the stomach, this approach is unusual and not advisable. However, a case is recorded Hagen in which this approach was the only one possible. Through the gastrocolic ligament, this is the best approach and it is employed more frequently than any other. Retroomental, the omentum is lifted and put the stretched. The serosa of the transverse colon is incised along the line of a junction with the omentum. A finger is introduced into the opening thus formed and the bowel is separated bluntly from the omentum. Thus, a large opening is made which exposes the posterior wall of the stomach, the pancreas, and also the third portion of the duodenum. Through the mobilization of the duodenum in order to reach the posterior surface of the head of the pancreas, this is an excellent approach to the posterior surface of the head of the pancreas. Here are some photographs of operations of pancreas. Through the transverse mesocolon, this approach is not advisable, particularly if drainage through the anterior and abdominal wall is contemplated. Now we will talk about posterior route. This is a possibly only when surgery of the tail is contemplated. The body of the pancreas is not accessible by this route since the spinal column lies behind it. This route is not advisable for the head on account of the important structures lying behind the head and the poor accessibility of this region. Operations for the tumor of the pancreas. There are two kinds of operation, radical and palliative ones. Radical operations include pancreatoduodenal resection. Its indications are cancer of the head of pancreas, cancer of intraduodenal part of common bile duct, and cancer of the major duodenal papilla. Palliative operations include anastomosis between the intrahepatic bile duct, anastomosis between the gallbladder and duodenum, anastomosis between the gallbladder and jejunum, anastomosis between the gallbladder and stomach. Stages of the pancreatoduodenal resections. First stage, mobilization of the duodenum of the pancreas and distal part of the stomach. Second, intersecting the common bile duct and duodenum. Third, removal of the head of pancreas, part of the stomach and superior part of the duodenum. Fourth stage, applying anastomosis between the common bile duct, stump of pancreas and jejunum, remaining part of the stomach and jejunum. Operations for acute pancreatitis. The aim of the operation is to incise the capsule so as to relieve the intracapsular pressure and to prevent any further compression of the blood vessels and thus increase the resistance for the gland and to prevent the escape of exudate into the free peritoneal cavity by walling off the gland from the rest of this cavity. The operation then is as follows. Step 1. The abdomen is opened by a midline incision extending from the ensiform process down the umbilicus. Step 2. The gastrocolic ligament is cut and the stomach is turned upward, thereby exposure the pancreas. Step 3. The lesser peritoneal cavity is packed with rolls of gauze which surround the pancreas and the ends of which are brought outside the abdominal cavity. Step 4. The capsule of the pancreas is incised in several places in a direction parallel to the pancreatic ducts and a gauze drain is placed over the incised capsule. Step 5. Cholestestomy is done or choledostomy if the cystic duct is blocked by a stone. Cholestestomy is just an important step of the operation as the others, since the external drainage of bile will prevent it from running into vein-sunk ducts and infecting the pancreas, which is the most important etiological factor in producing pancreatitis. No attempt should be made at this stage. Do any radical biliary surgery. This should be deferred to some future time when the condition of the patients improved. Acute pancreatitis, plain film findings, cutoff sign, dilated colon to the mid transverse colon, no air seen beyond splenic flexure. This is due to extension of inflammation along mesocolon. Cutoff sign and ileus, white arrows points to transfer colons, cut off at splenic flexure, no air in descending colon, transverse colon representing small bowel loops with air suggestive of ileus. CT findings of acute pancreatitis. Post contrast, diffusely enlarged pancreas with low density from edema. Note the density pancreas is less than liver and spleen with fourth contrast. Pancreas is wider than abdominal aortic diameter, including that it has increased in size. Colon, stomach, pancreas. Acute pancreatitis, phlegmon, inflammatory mass. Phlegmon, pancreatitis classification, peripancreatic facial infiltration, stomach. Acute pancreatitis necrosis. Here white arrow shows no enhancement of pancreas with fourth contrast, normal enhancement in tail pancreas, stomach. Acute hemorrhagic pancreatitis and last tail of pancreas. Here white arrow shows increased density in the large tail of pancreas due to blood, facial changes adjacent to tail of pancreas due to inflammation. Thank you very much for watching my presentation. Have a nice day.